Imagine standing out in a field, sun's warm, that smell of horses and hay. You hear the hooves, maybe a soft nicker, and you lean in close, listening to that heart, strong beat, steady. But then maybe, just maybe, you hear this little whisper, something not quite standard. So that whisper, that's what we're diving into today. We're looking deep into equine hearts, specifically at a condition called Patent Ductus Arteriosus, PDA for short. You've given us some really great sources, fantastic stuff that helps us understand what it is, why it's important, and, how it really affects these amazing animals. Our job is to pull out the key info, get you up to speed thoroughly, but hopefully pretty quickly. So, yeah, get ready for a trip into the surprising world inside a horse's chest.
It's really fascinating, isn't it, how different things are before birth versus after? And PDA, well, it sits right at that transition point. See, in the foal, before it's born, there's this special blood vessel. It's called the ductus arteriosus.
Yeah.
Think of it like a temporary highway bypass. It lets blood go straight from the pulmonary artery over to the aorta. It just skips the lungs entirely because, well, they aren't breathing air in there.
Oh, right, a shortcut, because oxygen's coming from the mare, not the foal's own lungs. Makes sense.
Precisely. But then birth happens. The foal takes its first breath, and bam, everything changes. Oxygen levels shoot up in the blood, and these hormones, prostaglandins, that were keeping the ductus open, their levels plummet.
Okay.
And those two things together, that's the signal. It tells that bypass vessel, okay, time to shut down. Normally, it constricts pretty fast.
Yeah.
Functionally closed within maybe 24 to 96 hours. Full anatomical closure usually takes about 4 days.
Yeah.
You might even hear a little murmur from it for up to a week in a perfectly healthy foal before it seals up completely.
So the patent part means it fails to close, it just stays open. What actually happens then inside when that switch doesn't flip?
That's exactly it. Patent just means open. And when it stays open, blood doesn't follow the right path. Pressure's higher in the aorta than the pulmonary artery. So blood takes the easy route and shunts backward. From the aorta back into the pulmonary artery.
Oh, okay, so it's flowing the wrong way.
Yeah, a backward flow. And this causes what we call left atrial and left ventricular volume overload. Basically, the left side of the heart is getting way more blood dumped into it than it should, cycle after cycle.
Like trying to pump way too much fluid constantly.
Exactly. It's under constant strain, getting stretched out, becoming less efficient.
Yeah.
And the size of that open duct, well, that makes a huge difference.
Right, so a bigger hole means a bigger problem.
Absolutely. The bigger the PDA, the more blood shunts back, the worse the overload. With a large PDA, over time, this stretching can even affect the mitral valve, one of the main heart valves. The ring around it, the annulus, gets stretched. The valve doesn't seal properly anymore. That's mitral regurgitation.
And that just adds to the problem.
It does. Pressure builds up in the left atrium, then backs up into the pulmonary veins, into the lungs.
Oh, yeah.
Eventually, you get the clinical signs of left-sided congestive heart failure, CHF. And it's important to remember, PDA often isn't alone. It can be part of a bigger picture, more complex heart defects going on, too. Finding a PDA can sometimes just be the tip of the iceberg.
So why? Why does this happen? Is it just like a developmental hiccup, or are there specific things that stop that vessel closing?
Well, fundamentally, it is a congenital defect, born with it. The root cause is that the smooth muscle inside that ductus arteriosus just fails to constrict like it should. It doesn't get the memo from the increased oxygen and the drop in prostaglandins.
Okay. And are some foals just more likely to have this happen, like risk factors?
Yeah, definitely. Premature foals, or dysmature ones,
Yeah.
their cardiovascular system might just not be mature enough for that quick switch at birth.
Yeah.
They're at higher risk.
Makes sense.
Also, things like hypoxia, lack of oxygen around birth, or neonatal pulmonary hypertension, which is high blood pressure in the foal's lungs right after birth. Neonatal respiratory distress syndrome, too. And surprisingly, perhaps, things done to the mare can matter. If a mare was treated with certain drugs, prostaglandin inhibitors, late in pregnancy, that could potentially interfere with the foal's natural closure mechanism.
Wow, that's a direct link back to the mare's treatment. What about genetics? Does it run in families?
That's a good question. In horses, we don't have definitive proof it's directly inherited, like in some other species, like dogs, but it is known to be heritable elsewhere. What we do see in horses is that PDA as an isolated thing, just by itself, pretty rare, but pops up more often when a horse already has other more complex congenital heart issues.
Oh.
And the sources do mention that Arabian horses seem to show up with these complex heart defects more often, so maybe a predisposition there. As for when you find it, well, usually vets pick up murmurs right away at the newborn check. So diagnosis is most common in neonates, young foals. But Technically, you could find it later in life, too.
Okay, so if you're an owner or a vet listening,
Huh.
what are the signs? How do you actually hear or see this? What are you looking for?
Right, the clinical picture. Well, sometimes, like I said, if it's small, it might just be an incidental finding, no obvious signs. But usually, if it's significant, it's tied to other heart issues. But the absolute classic finding on a physical exam, it's this sound. Vets call it a machinery murmur.
A machinery murmur. Wow, what does that even sound like?
It's really distinctive. You know how that heartbeat has two parts? Systole, the push, and diastole, the fill.
Yeah, lub-dub.
Right. Well, this murmur, you hear it all the way through both. It doesn't stop, like a continuous whirring, humming, like machinery running constantly. It's usually pretty loud, maybe a grade 3 to 6 out of 6. And you hear it best over the main pulmonary artery area, left side of the chest, up near the base of the heart, maybe third or fourth rib space. Sometimes you can even feel it, like a buzzing or vibration under your hand. We call that a thrill.
Okay, wow.
And here's the key takeaway. If you hear that continuous murmur, and the foal is more than 7 days old, that's generally considered diagnostic for a PDA, pathological. Now, sometimes it might linger a bit longer, maybe 10 days, and still close, so you watch carefully. But that 1 week arc is a really important flag.
Got it. 1 week. So that sound is the big one. What else might you see, especially with the more common left to right shunt?
Good question. So beyond the murmur, with those medium to large PDAs, you'll often feel what we call bounding arterial pulses. The pulse pressure is really wide. It feels strong, almost too strong, like the blood is just running off into the lungs too easily. You can feel that really well in the femoral artery inside the hind leg.
Like a real surge, then maybe it drops off fast.
Kind of, yeah. It feels very forceful. Then you might see signs related to the heart working too hard, the lungs getting congested, things like exercise intolerance. The foal gets tired really easily, doesn't want to play, maybe doesn't suckle well, fails to gain weight properly, failure to thrive.
They're a little guy.
Yeah. And tachypnea, breathing fast, or dyspnea, difficulty breathing and labored breathing, especially when they try to exert themselves. Maybe even a cough, if there's fluid building up in the lungs. In severe cases, you might notice their gums or inside their eyelids look pale, or even a bit bluish. That's cyanosis, lack of oxygen. And then in really advanced cases, the classic signs of heart failure. Edema, like swelling under the belly, and maybe the jugular veins in the neck look really full and distended.
Okay, so that's the typical picture, but you mentioned a rarer type, a reverse shunt, right to left. How's that different? Sounds serious.
It is very serious, and thankfully much rarer. This happens if the pressure in the pulmonary artery gets so high, usually from long-term damage, that it actually becomes higher than the pressure in the aorta.
So the flow reverses direction completely.
Exactly. Now, deoxygenated blood from the right side flows from the pulmonary artery into the aorta, mixing with the oxygenated blood going to the body. And the really key sign here, the hallmark, is something called differential cyanosis.
Differential cyanosis? What's that?
It means different parts of the body have different colors. Because the ductus arteriosus connects after the arteries branching off to the head and front legs, the deoxygenated blood mostly goes to the back half of the body. So the gums, the eyes, the cranial mucous membranes might look pink, normal, but the membranes further back, like the vulva in a filly or the prepuce in a colt, will look bluish, cyanotic.
Whoa, so the color difference literally maps out where that bad blood is going. That's wild. And a huge diagnostic clue.
A massive clue, yeah. Other signs with this reverse shunt are severe exercise intolerance, maybe even collapsing because they just aren't getting enough oxygen. And often polycythemia, the body tries to compensate for low oxygen by making tons more red blood cells so the blood gets thick. And interestingly, with this reverse shunt, that classic machinery murmur, it might be gone or very quiet because the pressure difference driving it isn't there anymore.
Okay, so you suspect PDA from the signs, the murmur. How do you confirm it? How do you really get a look inside? What's the definitive test?
Right, confirmation. The absolute gold standard, the test that really tells you what's going on, assesses severity, looks for other issues. That's echocardiography, an ultrasound of the heart.
The echo. Okay, what makes it the gold standard? What does it show you?
Well, it lets you actually see the heart chambers. You can see if the left atrium and left ventricle are enlarged, dilated, maybe looking kind of rounded because they're overworked.
Yeah.
You can see if the pulmonary artery itself is bigger than it should be.
So you see the physical changes?
Exactly. And you use Doppler. Color Doppler lets you visualize the blood flow. You can literally see that turbulent jet of blood shooting from the aorta back into the pulmonary artery. Continuous wave Doppler measures the speed of that flow. It confirms the shunt is there, and helps assess pressures. You can also look for secondary things like signs of high blood pressure in the lungs, pulmonary hypertension, and importantly, check for any other heart defects that might be hiding there. It gives a really complete picture.
Yeah, I can see how that would be definitive. Are there other tests that help fill things out, supporting diagnostics?
Yeah, absolutely. While the echo's the main event, other tests provide supporting evidence. An ECG, electrocardiogram, looks at the heart's electrical activity. It can show patterns suggesting chamber enlargement or pick up arrhythmias like irregular heartbeats, atrial premature beats, or even atrial fibrillation, which can happen in severe cases.
Okay, electrical map. What else?
Thoracic radiographs, so chest x-rays, they can show signs like increased pulmonary vascularity, meaning the blood vessels in the lungs look more prominent because they're carrying extra blood or fluid. They can show if the overall heart shadow looks enlarged. Sometimes you might even see a little bulge on the silhouette where the ductus is, called a ductal bump. If there's heart failure, you might see signs of pulmonary edema, fluid in the lungs.
So x-rays give the bigger chest picture.
Right. Then there were more specialized, more invasive things. Cardiac catheterization involved threading catheters into the heart and blood vessels to directly measure pressures and oxygen levels. You'd find higher pressure and higher oxygen in the pulmonary artery blood than normal with a PDA. And if you suspect arrhythmias that aren't showing up on a resting ECG, you might do 24-hour Holter monitoring, where the horse wears a portable ECG recorder.
Gotcha. And blood work, anything show up there usually?
Typically, routine blood work is normal, with a standard left-to-right PDA. The exception is with that rare reverse, right-to-left shunt. Because of the chronic low oxygen, the body makes extra red blood cells, so the packed cell volume, the PCV, might be elevated. That condition is called polycythemia.
Okay. And is it easy to mistake PDA for something else? Other things cause murmurs, right?
That's a really important point, differential diagnoses. Not every murmur is a PDA. You need to rule out other things, like innocent physiologic flow murmurs, which are common in young foals but usually softer and only happen during systole, or maybe a ventricular septal defect, a hole between the ventricles, sometimes combined with aortic valve leakage. The echocardiogram is really the key to telling these apart accurately.
Makes sense. So you've got the diagnosis, PDA confirmed. What happens next? What are the options? And, the big question, what's the outlook for the horse?
Right. Treatment and prognosis. It really varies. The approach depends heavily on the size of the PDA, whether there are other defects, and if the foal has clinical signs. For tiny PDAs found incidentally, maybe just monitoring is needed. For really large ones or complex cases, sometimes it's more about palliative care, just managing symptoms.
So definitely not a one-size-fits-all situation.
Not at all. For a very young foal, like under a week old, with a small murmur and no signs, you often just wait and see. There's still a decent chance it might close on its own. And some horses live their whole lives with a very small, silent PDA and do just fine.
Okay. What about medications? Can drugs help close it, like in human babies?
That's where it gets tricky. Drugs like indomethacin and NSAID are used in human preemies to encourage closure. But in foals, the success rate is, well, much lower, pretty variable, and there are significant risks like stomach ulcers or kidney issues. So it's not a go-to solution. If the horse develops heart failure, then medications become important for managing symptoms, diuretics like furosemide to get rid of excess fluid, maybe ACE inhibitors long-term, and antibiotics if they get secondary infections. But drugs generally don't fix the PDA itself in foals.
So if it needs closing and meds don't really work, what's left? Surgery.
Surgery is the definitive fix. Surgical ligation, basically tying off the open ductus. It requires specialized thoracic surgery, opening the chest under general anesthesia. It's the gold standard for closure.
When would you do that?
It's indicated for those moderate to large PDAs that are still open after that initial week or 10 days, especially if they're causing problems. And timing is critical. Ideally, you want to do it early, maybe between 1 and 3 weeks of age. That's to prevent irreversible damage, like severe pulmonary hypertension or heart failure setting in.
But I imagine that's a big, expensive surgery, especially on a young foal.
It is, and that's the tough reality. While surgery offers the best chance for a cure, especially for potential athletic careers, it's often not considered financially feasible or practical for many owners, especially aiming for high-level performance. It's a significant procedure with associated costs and risks.
That's a really difficult spot for owners. Are there less invasive options like the coils or plugs they use in people or dogs?
Interventional catheterization, yeah. Using devices delivered via catheter to plug the duct is being explored in horses, but it's still largely experimental or emerging. The sheer size of the horse heart and vessels makes it much more technically challenging than in smaller animals or humans, so not yet a routine option.
Okay. So putting it all together, surgery is ideal but difficult. Meds manage symptoms. What does the future actually hold for these horses? What's the prognosis?
It's a real spectrum. For a foal with a small PDA that closes on its own, or one that stays tiny and causes no problems, excellent prognosis, normal life expectancy, likely capable of lower-level athletic work.
That's good news for some, at least.
Yeah. Now, for the moderate to large PDAs, the common left-to-right kind, if it's untreated, the prognosis is poor. Many develop congestive heart failure and, sadly, don't survive past maybe 1 or 2 years old.
Oh, wow. That's stark.
It is. But if they get surgical ligation, and crucially it's done early before irreversible lung damage occurs, then the prognosis is actually good to excellent. Good chance for long-term survival and potentially even a decent athletic career, depending on the horse.
So early surgery really can be life-changing if it's an option.
Absolutely key. Then you have the bad scenarios. If that reverse right to left shunt develops, prognosis is grave. That signals severe permanent pulmonary hypertension. There's no effective treatment, and lifespan is very short. Similarly, once a horse develops signs of congestive heart failure from any PDA, the prognosis shifts to guarded or grave. You can manage symptoms for a while with supportive care, but the underlying damage is usually too severe, and euthanasia often becomes the kindest option.
That's incredibly tough. For the horses that do okay, maybe with a small managed PDA, what about riding them? What level of activity is safe?
It depends. Horses with small asymptomatic PDAs might be able to handle lower levels of athletic work, but, and this is important, annual echocardiograms are really crucial to monitor things if they are being ridden. You need to ensure it's safe.
What are you looking for on those follow-up echoes?
A major warning sign is if the pulmonary artery starts to dilate, to get bigger. That's a red flag. It increases the risk of a catastrophic pulmonary artery rupture during exertion. If that's seen, ridden work should absolutely stop. Also, if a horse with a PDA develops an arrhythmia like atrial fibrillation, they need a full cardiac workup to figure out what level of activity, if any, is safe for them.
So it really boils down to owner awareness and careful vet monitoring then. Their role seems absolutely critical.
Absolutely vital. Owners need to be vigilant, monitor the horse's heart rhythm regularly. Anything unusual, besides maybe a normal drop beat here or there, warrants getting an ECG. Watch closely for subtle things. Are they getting tired faster than usual? Is their breathing heavy during or after work? Taking longer to cool down? Is their resting breathing rate or heart rate creeping up? Any coughing? Any of those signs pop up, call the vet for a cardiac recheck. Don't wait.
Okay, so wrapping this up, we've covered a lot about PDA, from the fetal bypass to machinery, murmurs, and surgical challenges. Looking ahead, what does this all suggest for equine cardiology? Given that early surgery works best but is often impractical, what's the next frontier? Could we see better, maybe less invasive techniques become reality, or maybe even genetic screening to catch risks earlier? What might help more of these horses live full, healthy lives despite being born with this?